Okay, then here we go for our last session of the day. Then we'll deal with tumor and some advanced techniques such as spectroscopy for fusion and diffusion imaging. Well, what about the challenge in neuro-oncology, which are very specific to neuro-oncology when compared to any other disease of the brain? Then first, is it a tumor when you see any kind of mass or microscopic abnormalities, and is it a tumor? And what kind of tumor? Of course, is it intra or extra axial, as Pedro explained? Is it primary or secondary? Is it unique or multiple, benign or malignant? And what about the different subtype? And we'll see that we can play quite far in guessing the subtype of tumor we're imaging. And when you when someone is referred before surgery, you can try to map the main functions and even the main tracks of neurons. And after, it's a follow-up story. And first, you know that it's in the natural history for the low-grade glioma to move into high-grade gliomas. And we will follow up this patient and to pay attention if there's any change in the tumor type. What about the response to treatment? And we have to be familiar now with pseudo-response. And sometimes there's a progression of tumor, but we know there's also pseudoprogression. And then those techniques, spectroscopy, diffusion, perfusion imaging, is going to help you to better recognize the real events from pseudo events. Then first, we'll start with perfusion imaging. You know the principle we'll use. I will only focus on dynamic susceptibility contrast. I won't mention ASL. Even if it's interesting, I guess it's not reliable enough in this topic. Then we use dynamic susceptibility contrast of the first pass of an intravascular contrast agent, gadolinium-based, to represent the vascular bed. And the vascular bed in a voxel is the cerebral volume. Then in one voxel, you have a certain percentage which is related to some blood vessel with circulating blood. You must have an idea that about 4% of the brain parenchyma is occupied by brain vessels. 4%. There's some okay. Of course, you will have an interest in dynamics, but the fact is that in tumor we mainly focused on blood volumes, and I will talk only on blood volume in this talk. There's some limitation, of course. What about the quality of image? You have some deformation or artifacts due to the API technique or the T2 star technique, and you have also susceptibility artifacts responsible of some lack of signal T2 star, especially related to blood or calcification. And you have this problem of permeability. We'll talk about permeability again. And what about the post-processing? Then how to handle this problem of permeability? We'll talk about this again. Do we have a global approach, or do we have to implement the way the contrast agent will get into each voxel? Then that's what we call the arterial input function. And we'll see that usually in tumor, we don't really pay so much attention on the arterial input functions, rather important in stroke, where you may have really high disturbance of the arrival of the bolus into the voxel. And of course, quantification is always very tricky using MR. The main application in neuro-oncology is to try to determine whether there's any kind of hypervascularization and suggesting that there's a neuroangiogenesis. We'll see this in a moment. And this is a general principle. You get a baseline, then you inject a bolus of contrast agent, actually using MR. And when you scan people with T2 star, you will have a signal drop due to the transit of the bolus into your voxels, and you will keep measuring the signal change a long time, and then it will normally go back to baseline. And this probably we assume that the entire quantity of bolus or tracer that you put on the entry side, you will find it on the exit side. Then the quantity that is injected here should be estimated here. And all this signal change is proportional to this quantity. Of course, if there's any kind of leakage, I mean permeability normally, then you can only assume that what you get here at the exit, it's at the same amount on the entry. And then you will have to handle with this leakage problem, permeability problem. Then first, we will try to identify neurogenesis. It's a very important point because in glioma, for instance, it's what state on the pathology analysis from a low grade to a high grade. I mean, the level of angiogenesis is very important to determine because the quantity of abnormal vessel will also be related to the severity of the tumor, to the grade of the tumor. Then here you can see a CBV map, and on the border of the tumor, you have a contrast enhancement, and you also have an increase of cerebral blood volume. And it seems there's a relationship between the contrast enhancement and the neoangiogenisis and the hypervascularization. But this is not exactly true. If you have a contrast enhancement, most of the time it's due to a leakage. It's due to an abnormal permeability of this tumoral vessel, and then the gadolinium will get into the brain. You see, here the parenchyma do not normally enhance because they're brain-blood barrier, which is normally preserved, except in certain cases of abnormal tumoral vessels. Okay, then this you can see, for instance, you have a lot of vessel everywhere. You don't always have an increase of contrast. Okay, then to have this increase of contrast, usually you need to have a leakage. And once you have a leakage, your assumption that the brain-blood barrier is preserved is threatened in a certain way. It's not true anymore. But of course, perfusion imaging allows you to identify neoangiogenisis without any leakage. Here, for instance, it's the same tumor, but a little bit higher. You see, you still have neoangiogenisis, but you don't have any contrast enhancement. And here, in this area, you don't have any leakage. Okay? Then how does it work? Again, here is a CBV map. You have a tumor in this area. Then you will try to estimate if there's an abnormal vascularization, an increase of vascularization. You will calculate, you won't take the CBV for itself because the quantification of the cerebral blood volume and all these parameters except the temporal parameters, but all the volumic parameters is not so reliable because the relationship between the signal change and the volume or the quantity of contrast agent is proportional, but we never really know how proportional is it. Sometimes it can be saturated and so on. Then it's linear in a certain part of signal change, but not always. Then you have to compare. You compare your region of interest, your major region of interest, with a kind of reference, and you will calculate a ratio between your abnormal region of interest with this reference. That's why you won't talk about CBV of a tumor, but of a ratio CBV, RCBV, little r CBV. Okay, and then you have to combine the two regions of interest. Here in pink, you see the reference. In the white matter, you don't take the gray matter. Okay, if you take the gray matter, you can be flown by some vessels, and the cortex has also an increased CBV. now it's since we're performing quite regularly this measurement, it has been decided that when you compare, you don't take the mirror, but you take the mirror region of interest, but you take region of interest in white matter. Okay, and then you measure here in this way, and you will take the region of interest into the tumor. And you will see, as I said, you need to have a baseline, and the longer is the baseline, the better it is. Usually, let's say 20, 30 seconds is quite good. Here is quite a bit short. And you will have your signal change due to the transit of your contrast agent. And I said that normally the entirety of the signal change is due to the total quantity of your agent. Okay? Then normally the integral above this curve is a good marker of the cerebral blood volume. You have to find all your tracer agent in this blood volume, in these vessels. Okay? And normally after it should go to the baseline, except when you have an abnormal permeability, a leakage of contrast agent, it may go above the baseline. It's due to a T1 effect. Then if you have an important permeability, an important leakage, what may happen is this curve may be distorted and move upward. And then when you try to measure the integrate here, you may underestimate the real CBV, only because a significant part of the product of your tracer is still remained into the brain and didn't go out of your voxel. Okay, then to try to handle this problem of permeability, you have a different solution. Here is an illustration of a curve. Then this is not a signal-to-time curve. It has been changed into delta R2 star. Anyway, it's a conversion. It's a conversion of the signal change. You see that the curve will get under the baseline when it's uncorrected. Then in a certain way, when you'll try to estimate the area under this curve, it should be quite different if there was no leakage. Then the idea is try to imaging. You remove that up in order to better estimate the leakage. Okay, here is this figure is quite a bit full, but because here you have the first pass, and here you have the second pass of the gadolinium. Then you have to remove this second pass again, and then you will draw a kind of line here to estimate better properly. It can be done by mathematically. It's in a correction for the leakage. You can do it on mathematics. Okay. But in practice, you can do it also in a different way. You will inject a preload gadolinium in order to saturate the interstitial tissue. Okay, you will first provoke the contrast enhancement. Once the gadolinium is in the tissue, then you measure your first pass. Okay, and this gives this kind of map. You can have, for instance, here when you have uncorrected CBV, you may have a ratio of 4.9, and if you try to correct the CBV, whether using a preload or using modelization of the leakage, you will find that your corrected CBV is higher. Okay, and you can even measure now having a measure of the permeability, but you need a longer acquisition and so on. Then it's not from regular practice. Anyway, perfusion now is a very common tool to estimate tumoral disease. What you have to remember is when you compare the reference here in green, and your main region of tumor region of interest, when you see the area above this curve are quite similar, you have a ratio very close to 1. Okay, this ratio very close to 1 without any leakage. You can find it in low-grade glioma. Okay, and in pseudoresponse. We'll see it in a moment. When you have a very high ratio of CBV, superior to 2, we could say 1.8 for the specialist, but here we will say 2. With a variable permeability, you will see observe this kind of change in malignant glioma, in metastasis, especially when you have hypervascular metastasis, in meningioblastoma, and also in meningioma. Okay, and when you have RCBV close to 1 plus permeability, you will see this in lymphoma, pilocytic astrocytoma, rhabdomyosarcoma, and pseudoprogression in many other conditions like demyelination, abscess, or any kind of granulomas. Okay, then remember these 3 different patterns. You have the highly vascular pattern, don't care about permeability. It sounds quite bad in a certain way, except for meningioma, which is a normal highly vascular tumor. But when it's intraaxial, you have to think of glioblastoma or malignant glioma, metastasis. You have this normal perfusion in low-grade glioma here. And when you have this leakage, you can observe it in many different conditions, including lymphoma and pilocytic astrocytoma. Then first, besides this characterization of the tumor, you have to deal with pseudoprogression. It's the same principle for radionecrosis, but now radionecrosis are very rare. It has been observed quite a long time before when radiotherapy was not so focused as it is now. Now radionecrosis, I didn't see any for more than 10 years. But pseudoprogression is quite common. And here is a patient referred for an anaplastic astrocytoma, and it was decided of radiotherapy and temozolomide. And you see this tumor with certain foci of contrast enhancement. Okay, you see the tumor, how it looks 2 months after. Okay, so there's an increase of contrast enhancement. The edema has also increased. And when you measure the perfusion, you see that the CBV, there's no increase in CBV. Then this is not due to an abnormal quantity of vessel with an important leakage. It's only leakage. Okay? Then you have to be very familiar with the fact that even in tumor, it's not because there's a contrast enhancement that it's due to hypervascularization. Okay? And that's why perfusion imaging is interesting. And you see 18 months later, okay, then all this pseudoprogression and reaction to radiotherapy disappeared. You'll still have some sequela, and the tumor keep having a story, but this acute phase and inflammatory reaction to the treatment is now over. Besides this pseudoprogression, you have also pseudoresponse. Okay, this pseudoresponse were described for more than 10 years now. Once we introduce the bevacizumab, it's an anti-angiogenic. It's an antibody against the vascular growth factor. It's a little component that enhance the production of vessels. And the fact is that this agent will lead to a decrease of contrast enhancement and a decrease of permeability. Okay, but at the same, it doesn't mean that it cures the tumor. In a certain way, it only cures the vessels. Okay, it only means that the vessel seems to be cured. Okay, and the fact is that the tumor itself will keep growing on. That's why the T2 abnormality will increase. And usually you can detect sometimes antibodies against this bevacizumab. Okay, here's an illustration from the literature. You see the first examination, you have a tumor with abnormal enhancement all over, and less than a month after, you see that this enhancement has almost disappeared. Okay? Then you wait 2 more months, you see that it reappears. Then actually it was only similar to a good response, but the tumor was still there, and at the same time you see the infiltration in hyperintensity on T2 was still increasing. I have to hurry up. Then here is another case. It's an anaplastic astrocytoma, grade 3. You see that there was some hypervascularization. Here, an increase of signal change with permeability. Only 3 days after the administration of the anti-angiogenic, you start to see the absence, you start to see a decrease of contrast enhancement. The CBV has decreased as well. You see 2 months after, it seems that it was really better, except maybe a little foci posteriorly. And you see 5 months after the beginning, everything has restarted. Then it seems to be quite good. The vessel, in a certain way, were healed, but actually the tumor itself was still there and kept going on. Okay, what about spectroscopy? Then spectroscopy then will use the difference across chemical shift. The chemical shift across the nuclei within different molecule will change with the environment to represent the normal and abnormal dissolved metabolites. There are some limitation, of course, like always, and the quality of the acquisition is very critical, and especially when you are very close to the skull, very close to calcification, very close to blood, the sheen is not always appropriate. And here is an example of spectroscopy you cannot interpret properly. We say that the signal-to-noise ratio should be less than 1/3 of the peak of NAA. It's a minimum. Here you see then the signal-noise ratio is almost as high as the peak of the NAA. It was due because of blood into this lesion. Okay, this is a normal spectrum. You have a long TE where you see, then you see the baseline is quite linear. Okay, whoops, can I go back, please? The spectrum is quite linear, and you see that on the long TE you have a large peak of NAA and smaller peaks, and we'll mainly focus on choline and creatine. What is always true is that in normal brains, and the NAA is above the choline, okay, and usually the ratio between choline and creatine are quite similar. Usually it's a little bit below, but sometimes it can be a little bit higher. But the ratio, if you measure it, is always less than 1.3. When you have a shorter TE, you may be more sensitive to different compound that may be out of the topic today, but you're more sensitive to abnormal compound such as lipids. Then here we'll see the main peak of interest in neuro-oncology. There are many other peaks, but let's say then we'll focus first on the peak of choline. The peak is at 3.2 ppm, and the advantage of spectroscopy is that you have real numbers. And you have to really look at the value of each peak on this slide. Then choline is at 3.2, okay? It's always positive, even on short and long TA. What you have to keep in mind that the choline sometimes can be a little bit above the creatine, but never so far above. Then we say that the ratio have to be below 1.3. And it has always to be below NAA. Here is an abnormal peak of choline. It's too far above creatine and too far above Na. It's referred to the cellular membrane turnovers. That's why in highly important membrane turnovers, such as in glioma, inflammation, and so on, this peak of choline will increase. When you have a tumoral abnormality, you will have an increase in choline. What about the lipids? The lipids, there are two peaks here. One peak, then you better see the lipids with a short TE at 35. Okay, there are two peaks, one peak at 1.3 and one peak at 0.9. And this marker is always abnormal. You shouldn't see any lipids normally, and usually it's related to necrosis. But again, it's not specific. We've seen there were some lipids in tuberculosis or in toxoplasmosis. In tumor, you see a lot of lipids in lymphoma, for instance, in certain metastases, and even in glioblastoma. Okay, and then when you have a glioma, having lipids, it's a sign of malignancy. And finally, the lactate. Lactate is always abnormal. Again, it's quite tricky because it's a double peak at 1.3, which is negative at long TE, okay, and positive with a shorter TE. It's always abnormal, and again, it's a very unspecific marker of necrosis. You may see this in tumors, of course, but also in infection, in stroke, and so on. When you have a low-grade glioma, seeing increasing of lactate is rather a sign of turning into a higher grade glioma. Okay, let's see some example. Here it's a abnormal peak of choline. You see the choline is higher than creatine and NAA, but there's no peak of lactate, nothing in lipids neither. It can be really interesting, especially in the diffuse midline glioma, because for certain lesion, it's very hard to get a biopsy. Okay, and now it has been stated that it's possible to cure this patient without any histological proof when the image are typical, and especially when you can demonstrate the nature of the lesion using spectroscopy, for instance. And you see here a peak of choline far above the creatine and the NAA on both echo time. Okay, and for the follow-up, you can follow the peak of choline as well. Here, a patient with temozolomide. You see, you have a high-grade tumor in this area. You see there's a huge peak of choline, almost no NAA anymore. And as far during the follow-up, you will start to see this peak of choline decreasing while you see the peak of NAA increasing. And it's in a certain way a marker of efficiency of the chemotherapy. Okay, then now let's move to something very easier, diffusion imaging. Diffusion imaging, then you know this principle from the stroke history. In tumor, it reveals mainly the cellularity of the tissue, then the tisular part, and for the necrotic part, it's going to help you to distinguish it mainly from abscess. Okay, and there's a lot of advance in this field, but let's say that it could be another time. Then here you see many different lesions. Okay, and you see that in this lesion you will have a decrease of a restricted diffusion here as a decrease of ADC on the edge of the tumor. In this case, in the core of the tumor. Here again on the edge. Here's the tumor. Well, then this refers to the cellularity of the tumor. The lower is the diffusion coefficient, the higher is the cellularity. Okay? And when you have a look at the necrosis, you see, for instance, a round lesion with peripheral enhancement, and you see that the necrosis on the ADC map here is increased. Okay, another case, quite a similar kind of lesion, and here the necrosis, the diffusion restriction is there's a diffusion restriction. Then you can easily distinguish what is a tumor, what is an abscess. Okay, and very one word to say that if you keep using this technique, you can also try to evaluate patient before surgery, try to identify the tract of white matter. Here's the corticospinal tract and its relationship within the tumor. Now the software are embedded on the acquisition and even on any post-treatment station, and it's very easily, you can easily track this kind of tracts. Anyways, there are still some limitation, because when you have a lower anisotropy, like in highly hyper T2 lesion, I mean, your software won't build any fibers into this hyper intense T2 lesion. Then what you see is what you expect, but you can hardly see bundles, fiber bundles into the tumor. And FMRI, a very simple word on FMRI, just to say that this is the kind of FMRI we would like. Try to map all the elegant area around this glial tumor before surgery. It's only interesting when you are talking about surgery. When you're not talking about surgery, it's research in cognitive neuroscience or physiology, but it's not medicine anymore. But when you're talking about surgery, you can map very easily the primary sensory motor activity of here's the end. Here you have the lips. Here in green you have the foot, and you also have the supplementary motor area in the middle. Okay, just to see that it's also quite reliable, especially when you deal with language dominance. Here, for instance, 2 examination in a patient having low-grade glioma in the middle frontal gyrus. You see, on the first session, we had this map in red, this kind of activation, with a balance of activation that was moved towards the LT hemisphere on the right side. And several weeks after we did the same examination, and we had this green map, and in yellow that was the overlaps. And you see, it's quite reproducible across session. Okay, then remember, patient history, always the same. What about the treatment, especially when you have to follow a patient? Perfusion is very interesting to identify neurogenesis and to try to distinguish from leakage. Spectroscopy is quite a bit tricky, but it's very useful to try to discuss diagnosis and to distinguish tumors from other lesions. Diffusion imaging is very interesting to try to identify highly cellular lesion, like lymphoma, for instance, the rim of glioblastoma, germinoma, and so on. And when surgery in elegant, when you have a neurosurgeon ready to go into elegant area, then okay, you can try to do functional MRI and tractography. Okay, then thank you for your attention.